Good evening, everybody. Welcome to our first community webinar for 2022, hosted by the Community and Researcher Engagement Program at Monash University's Central Clinical School, or CCS. I would like to start by acknowledging the traditional owners of the lands on which we meet today, the Wurundjeri people of the Kulin Nation. I would like to pay my respects to their elders, past, present and emerging, and recognise the rich traditions and continuing creative cultures of all Aboriginal and Torres Strait Islander peoples of Australia. My name is Professor Terence O'Brien. I'm head of the Central Clinical School at Monash University. I'm a clinical neurologist while my primary clinical area is epilepsy, I have a research interest and a collaborative interest in the area of dementia, and always very keen to learn more. So I'm very excited about this program. The CARE program, which stands for Consumer and Researcher Engagement Program, was originally developed to facilitate effective interactions between researchers within the Central Clinical School and members of the community who have a lived experience of a health condition or disease that we study in our school. By understanding and learning from this unique and valuable patient perspective, we ensure that research that we're undertaking is appropriate, is accessible, and is relevant to the needs of people impacted by their health conditions. An important part of our CARE program is to run a series of public webinars. These webinars are intended to provide you, as members of the community, with the most up-to-date information about the cutting-edge translational research being performed within CCS. This evening, our series of expert speakers will be discussing some of the exciting dementia research performed within the school and ways which research aims to improve diagnosis, therapy, and ultimately the outcomes for patients living with dementia. We'll also hear from two experienced consumer advocates who will share with us their insights into caring for their family members with dementia. This evening, approximately 6:30 p.m, we will conclude the presentations with a 30-minute Q&A session with our expert panel, who will attempt to answer as many of the questions as they can from you who are attending the webinar this evening. We have received a lot of questions, and so we may not be able to answer all of them, so we apologise for that. We'll get as many answered as we can. To find out more information from each of our speakers and panel members, as well as from the CCS CaRE initiative, please refer to the reminder email that was sent out to you and the PDF for the program. Before I introduce each of the first speaker, I want to cover some housekeeping items. Please feel free to add your comments or feedback in the chat box as we go. If you have a question, put it in the Q&A section, not in the chat box, and we'll try to get to that in turn. It's important to note that experts will not be able to answer everything that you may have, all the questions you have, but as I said, we will do our very, very best. So without further ado, I'd like to introduce our first speaker, and that is Associate Professor David Darby. David Darby is a cognitive neurologist in the Department of Neuroscience at Monash University and also a member of the Eastern Cognitive Neurological Clinic at Box Hill Hospital. He specialises in young onset and atypical dementias. His research program encompasses many disorders featuring cognitive impairments, including concussion, stroke, prodromal dementia, epilepsy, multiple sclerosis and migraine. Please join with me in welcoming Dr. Darby this evening, who will set the stage for us with an overview of dementia as a clinical disorder. Over to you, David.
Thank you very much indeed, Terry. So I've been given the brief of discussing dementia as a sort of an overview and also talk about some of the clinical aspects. I'd like to do this as a type of conversation, as if I'm speaking to someone and their family, for example, that's been diagnosed recently with one of the forms of dementia. So the obvious first question is, what is dementia? And we have a working definition that we use. It's an impairment in memory and at least one other cognitive domain. We talk about domains as being constructs involving things like language, visuospatial ability, executive abilities. Executive really is the higher elan of our thinking, problem solving, abstract reasoning, as well as things like social cognition, the ability to interact with people effectively within a society, and the sorts of things that go along with that. They have to be alert and clear in their thinking. So this differentiates dementia from someone who has a confusion or a delirium state. And typically, a patient with dementia has significant impairment of their function, such that they are effectively no longer able to be independent functionally. There are earlier stages, and the research is moving more and more into earlier stages so that we can hopefully diagnose and treat people in these earlier stages. We call these prodromal conditions in general, and they have a range of different names. And sometimes the distinction between the early stages and dementia are a little bit blurred because the definitions often depend upon changes in function, and that can be difficult at times to be certain about. The emphasis, though, as I said, is currently and in the future on earlier detection in these prodromal stages. I don't have time to talk about all the different types of dementia, but I'll mention some of them. Certainly the commonest one is Alzheimer's disease at any age. And then there are other ones, and about 100 different conditions that can cause dementia. Parkinson's disease has a number. Vascular disease, wear and tear, if you like, in the blood vessels of the brain causes vascular cognitive impairment. And then there are genetic diseases such as Huntington's disease. And then very rapidly progressive ones. The most common one, which you may have heard of is Creutzfeldt-Jakob disease, which is what we call a prion disease. But there are also very many rarer dementias that are particularly common in children or younger adults. So what are the symptoms of dementia is the next question. Well, we talk about cognitive symptoms, which are probably the most common. There needs to be a progressive decline, usually over years, but most of the time it's a relatively progressive decline, not stepwise, although in vascular dementia it can be stepwise. In some dementias it can fluctuate as well. So we particularly, though, look for a progressive decline. And in terms of specific cognitive domains, the commonest domain is, of course, memory decline. I like to distinguish between what we call rapid forgetting. Rapid forgetting is when somebody can retrieve information poorly, even though they might actually get it initially. After a delay, they don't spontaneously recall it very well, or may have forgotten it completely, because the information decays much more rapidly than it should. And when you then try and prompt them, they don't seem to do any better. Whereas a retrieval pattern, when you prompt them, even though they may not recall it, they often go confidently, yes, of course, now I remember. Now, the difference is important because, for example, rapid forgetting is associated with conditions that involve the inner parts of the brain, the inner part of the temporal lobe, for example, such as Alzheimer's disease or strokes that might affect that part of the brain. Whereas the retrieval pattern is not associated with those parts of the brain, but with other conditions, including psychological conditions such as anxiety and depression, including medical and systemic problems like thyroid disease or vitamin deficiencies, but also with neurological problems that can affect the deeper parts of the brain. And then other domains can be affected as well. And I mentioned those ones: language, visio-perceptual, visuospatial, and executive abilities. And it's the combination of these that helps us decide what the likely differential diagnosis, by that we mean the possible causes, could be. We have to take into account whether or not their attention and concentration is intact, because if it's not, then it's not a dementia, it's probably a confusion, and there are other causes of those. And we also have to be aware of how well they performed in life before this, what we call the premorbid intellect, and cultural and language factors as well. Have to take all that into account. There are also behavioural changes in some causes of dementia. Personality is very dependent upon the front parts of the brain and the connections to that, as well as behaviour. And I mentioned social cognition before, so the ability to interact effectively with other people is very important, and that can be affected early in some of the conditions that affect the frontal lobes. Psychiatric changes can also occur. Now, these can be very early. For example, in some patients who have Alzheimer's disease, one of the earliest changes is, in fact, depression. In some forms of Parkinson's disease affecting cognition, anxiety is a very common symptom early on. And often these come out of the blue in someone who has not had these conditions earlier in their life. So they can be a red flag that maybe this person is developing something unusual underneath this. And often once those conditions are treated, then perhaps the memory impairment or some other impairment starts to emerge. We sometimes see hallucinations, which can be very confronting for the patient and also their family. They can see people that are in the house or outside in the garden that other people don't see. They can even interact with them, which becomes a type of a delusion. They can misidentify, for example, their spouse and think that person's an imposter. All of these are very, very difficult behaviours to confront, particularly within the family. And I've mentioned irritability, very common in early Alzheimer's disease, for example, where it's a natural thing when someone forgets something to then remind them, and they don't remember that they've ever been told that before, so they can get quite shirty or irritated that they're being told that they should remember when in fact they don't. So irritability is very common, and it's a clue to perhaps not remind that person with a bit of raising of your voice or some emotion, because they will respond to that emotion in a negative way. Aggression is not that common early on in dementia, but it certainly happens, and it can be a reason, for example, for the need for medications or nursing home. All right, doctor, what are the causes of dementia? So I don't have time to go into all of these. As I mentioned, there's over 100 different causes of dementia, depending upon what age it starts, the clinical symptoms, whether there's a positive family history, which might suggest a gene. There are different causes for people who are over 65, most commonly Alzheimer's disease, but also vascular disease is very common and often contributes to patients with other forms of dementia. I've mentioned the Parkinson's disease and frontotemporal dementia, which can involve the frontal lobes or the temporal lobes. Any combination of those can have a series of different symptoms. But in older people, you can get a pure rapid forgetting problem that looks like Alzheimer's disease, but in fact is due to something else. And those mimics of Alzheimer's can actually be quite slowly progressive and perhaps only restricted to memory. So they can be quite different, and it's important to differentiate those, we think. Less than 65, it's a different story, and although Alzheimer's disease is still the commonest, many genetic causes of Alzheimer's disease can occur, particularly if the patient is less than 50. And these are more common than the other ones I mentioned, but Huntington's disease, functional disorders, where there's a psychiatric cause, also occur, many other causes. And if someone's less than 20, then we usually think of a genetic cause. So yes, children and young adults also get dementia. Very confronting when that happens. What's the pathology? Well, at the moment, most of the dementias seem to be caused by the buildup of toxic proteins, which then leads to a cascade of events with loss of neurons. In Alzheimer's disease, the trigger is a protein buildup of amyloid, which is either in excess if there's a genetic cause, or reduced clearance in people who have what we call sporadic Alzheimer's disease, where there's no genetic mutation or cause for it, and they get it generally a bit later on. Then there's a cascade in Alzheimer's disease leading to other protein changes and inflammation and vascular damage as well. Then loss of neuronal function, which is manifest by the clinical symptoms, as well as changes in the synapses, connections and shrinkage of the brain, what we call atrophy. The animal models are very helpful for us to work out, particularly medications that we might be able to use, but they're not perfect. And we're still trying to find better ways of predicting what our treatments might, or which treatments might work. So is dementia genetic? Also, most cases of dementia are actually sporadic, but it does depend upon the cause and also the age of onset. So in Alzheimer's disease, less than 5%, maybe about 3% are genetic. And typically, the symptoms for people with genetic causes occur much earlier in the 20s and 30s. All of the genes increase amyloid production, and often they have additional features as clinical features that we can see, such as jerking, epilepsy sometimes, or what we call spasticity, so increased tone and reflexes in parts of the body. There is one gene that was discovered in Iceland which decreases the amount of this amyloid protein, and those people are lucky in that they don't seem to get Alzheimer's disease or age-related memory problems. So that's possibly a clue for future treatment as well. Frontotemporal dementia is a lot more genetic in general, particularly if there's a family history with 2 or more affected family members, going up to even 80% chance of having a gene. And I've mentioned some of the genes which have horribly long names and funny abbreviations, which I don't really have time to go into now. Huntington's disease, you would have heard about, that has a mutation on chromosome 4. And there's a variable type of inheritance. We talk about these different types, and often the family history can help us work out what is the type of inheritance, and that's important for genetic counselling in terms of working out whether family members and offspring are at risk. So the risk to first-degree relatives, it's worth noting that in Alzheimer's disease, if there is not a family history, or even if there is a family history of first-degree relatives being involved, the risk only increases by a very small amount, at most 5 to 10% over the population. So at 60, it's 1% of the population, so maybe 1.1% in people who have a first-degree relative. But it doubles every 5 years, so that by 85 and above, which isn't a bad lifespan overall, the risk is about 45% of the population, and maybe about close to 50% in people with a first-degree relative with late-onset Alzheimer's disease. And the risk varies in other dementias. This is why we have neurogenetic clinics, because they're available to discuss the risks for people that are worried about the risks if they have relatives who might have dementia. So moving on, how quickly does dementia progress? So typically dementias progress and evolve over many years. They don't evolve over days, weeks, or months, unless there's a confusion or delirium state on top. And that's usually associated with some cause, which hopefully can be reversed. Faster or slower progression definitely occurs. So we sometimes see people who develop dementia within a year or two, but generally there's a different cause, such as Creutzfeldt-Jakob disease, one of those prion diseases I mentioned. The prodromal stages, remember these are continuous diseases, so the prodromal stages also can be many years, and often 6 to 8 years, for example, in Alzheimer's disease. And in Alzheimer's, there's a 20-year asymptomatic period before that as well. So finally, is a treatment, and I'm just going to rush through this. General measures are important. We know that a healthy lifestyle, particularly in midlife, involving regular exercise, particularly aerobic exercise, a balanced diet, such as the Mediterranean diet, which has lots of olive oil in it, for example, as well as other balanced food groups, a reduction of vascular risk factors, particularly please don't smoke, and early life issues as well, which I'll talk about in just one second. So these general measures are associated with a reduction of later life dementia, all-cause dementia. The early life factors mentioned there, education, socialization, and avoiding head injury. Not much you can do about that by the time you get to midlife, but it is important, hopefully, to have a good education and to be sociable as well. And then for specific dementias, at the moment, we only have treatments for very rare metabolic dementias, but we are still working in clinical trials, particularly in Alzheimer's disease and frontotemporal dementia that you'll hear about from Dr. Vivash. We are still looking for treatments in clinical trials and do need to have volunteers to help us. Symptomatic treatments are available for psychiatric problems and behavioural problems as well, although we often prefer non-pharmacological strategies. And I think that's all I've got, so thank you for your attention.
Thanks very much, David. That was a fabulous overview of dementia. Just to remind everybody, if you've got questions, please put it in the Q&A box and we'll address these at the end of the presentations. So next, for a bit of a change of gears, we have our first advocate, Mr. Malcolm Johnson. Could not be here today, but he agreed to sit down with one of our researchers and the CaRE program coordinator, Ange, for a chat about a week ago. We'll now share a brief video of that discussion.
I'm Malcolm Johnson. I'm a husband of my wife who's suffering from, or has been diagnosed from Alzheimer's in October 2018. This happened by the fact one day we were sitting in our kitchen, and Anne said, I can't make guacamole. And I said, what do you mean you can't make guacamole? You make guacamole for our meals many times. Oh, I can't do it. So I started to watch and see what Anne was doing, and there was a few little small things like forgetting things. And I thought, and she was writing in a diary and things that I thought, what are you doing that for? Anyway, I eventually went to the doctor and said, I think Anne's got a problem. And he said to me, no, I'm not. Has she ever lost her way when she's driving? And no. Tell me what she did. I explained. He said, no, I won't talk to Anne. He said, Anne should come to me if she's got a problem. We went home and didn't do anything about it. 2 months later, Anne said, oh, I think I might have a little problem. I'm forgetting things. And I said, right, we'll go to the doctor. We went to the doctor. Then I went through the test. Anne walked out and I said, well, we've got a problem. And she really didn't realise that she was being diagnosed with Alzheimer's. She felt that, well, I'm normal. I do these things anyway. Well, I'm not like that at all. And I said, well, okay, you failed the test. And I don't think, she still doesn't think, well, she knows she's got Alzheimer's because she's been told that many times by us. And we've been aware of it, but it really has been difficult for her to really comprehend that she has got that problem. Be extremely more tolerant. I have had difficulty at the start understanding why she would ask the question that she's already asked 15 minutes ago, 2 days ago, or has forgotten something that I assumed that she should have remembered. However, I'm now realising, of course, that that's part of the memory loss, and which I am suffering from as well at times. And I'm now a little bit more tolerant about her condition, and I sort of don't get upset about her condition as much. I've talked to a lot of people who have been through the situation, and I'm not aware. I'm finding it difficult to really understand what might be ahead, but I'm sort of treating a day at a time. I'm a great day at a time person. I believe that tomorrow morning, if I wake up, it's going to be a good day. It really is. Life's changes. You've got to be prepared to adapt. I think that you think that everything in your life is will continue in the same vein. I'm a cancer survivor anyway, and I have to say that I'm a realist, that every day is a good day, and I was lucky, and I'm still very fortunate, and I think that you just look on each day as being a day to wake up in the morning and then say, right, let's get on with life, and try and do as many things as you can under your own control.
So that's wonderful. We would like to thank Malcolm for his fantastic insights into living with dementia and living with person with dementia. So next we have Tara McDonald. who is also representing lived experience perspective. Ms. McDonald's is a passionate consumer advocate in our CaRE program, teaming up with some of Monash's basic researchers to ensure that their research work is patient-focused and patient-relevant. Her life has been impacted by dementia on several fronts, which she will share with you now. She's a dementia advocate in her own right, currently studying a Bachelor in Dementia Care at the University of Tasmania. Welcome, Tara. Over to you.
Thanks, Terry. Hey, everybody. I'm Tara. It's great to be here. Thank you. I just want to start with just something that's a little bit of an exercise. So if you put your hands together and clasp them like this, like you would normally, just sort of think about how that feels. Now, take them up and flip them over. And how does that feel? Most people that I do that with, they sort of say it feels a little bit uncomfortable. And you know what? It is. And dementia is uncomfortable sometimes, but it is what it is. So just take a minute, think about how your hands feel. And every now and again that you think about dementia, it's like, yeah, okay, it's going to be a bit uncomfortable. So thanks for doing that with me. One of the other things I just wanted to share with you is a quote that really I heard last year, and it really sort of stuck with me. And it's, what we can agree on is it is always now. But now is the shortest moment in our life. It's gone in an instant. The longest moments of our life are our memories and imagination. I think that's really, really poignant for when it comes to thinking about dementia. And believe it or not, it actually was said space, and it was actually said on a podcast that I was listening to, and the person that said it was Kanye West. So read into that what you would like. Moving on to, I suppose, my experience with dementia. So I've experienced dementia probably already 3 times in my life. So my first experience dementia actually when I was probably about 5 years old, when my nana was diagnosed with Alzheimer's disease. Unfortunately, I don't have a lot of memories, or I don't think I have memory without Alzheimer's disease. I remember though that when I was about 11 and she was in respite care and she caused a rush, was found in someone else's bed with them. And the care home that she was in was like, oh, this is an incident, we need to write it up. My pa was in bed with another woman, and the kids, including my dad, were like, well, we don't really quite know what to do with this. And so as I can see there's a whole lot of things going on, and I know it's got something to do with Nana's memory, but I'm not quite sure what's happened. And then when Nana moved on with her Alzheimer's care, I remember where she hadn't spoken for a long, long time. But I went in there one day and I had a red satin shirt on, and that was my first experience. So she was fixated on this red shirt, and she just sat there and was like, me, 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 me. And I remember being a kid going, this is weird. But I had this feeling inside of me that this is providing some type of pleasure for Nana. So I'm just going to go. And then one of the most significant memories that I have with my Nana is it was Christmas Day. And just before my family and I arrived, my Nana's sister had come to visit. She had her own health conditions, and unfortunately it was really tough for her to get there. But this one day she arrived and she'd spent some time with Nana, and walking out as we were walking in. And we got to Nana, we said, hey, Merry Christmas. And she turned around to us and she said, Ellie's just been here. And we all sort of went, she hadn't spoken in 3 years. And in that moment in time, she captured that beautiful interaction with her sister. And somehow she turned around, Eileen's just been here. And that started to make me realize that dementia was an incredible thing that creates incredible moments we possibly can. After my Nana passed away with dementia, my pa started, which was my dad's dad, so my Nana's husband, and unfortunately, because he'd spent so much time over the last couple of years driving from home to where Anna lived, he kept driving there. And unfortunately, he wasn't a particularly good driver anymore, and his spatial recognition had really, really diminished. And so I remembered Dad going over to Pa's house when he was either asleep or he was at one of my dad's siblings' houses, and he'd take parts out of the car because he knew that if the car didn't start, Pa couldn't drive it. But then I have to then ring Dad and say, oh, someone's been stealing parts out of my car, but it's okay, I found some new parts and the car's working again. And so it never actually got a solution until, unfortunately, the police had to take away his license. When Pa's dementia got worse and he ended up in full-time care, Dad picked him up and brought him home to visit. It was wintertime. And he was non-verbal at this point, and his motor skills or fine, they were starting to fade pretty quickly. And then one moment, Dad threw wood at him, and he caught it and he put it on the stack of wood. And so all of a sudden, Dad was throwing wood at Pa, and he's catching it, putting it on the stack, catching it, putting it on the stack. And it was the second time in my world where I realized that dementia was an amazing, could produce amazing moments that needed to be captured and need to be nourished. In 2015, my dad was diagnosed with Alzheimer's. And when it happened, we all looked at each other and we thought, okay, we know what we're in for. And my dad turned around to us all and said, kids, and my mum was there too, this is what it is. And that became our mantra. It is what it is. And so as Dad's dementia progressed, we'd get to a moment where we'd say, it is what it is. So I just want to share those moments with you because they're my experiences of dementia. I've got some other sort of thoughts and queries around, you know, what's changed and what hasn't changed in that time. But I think it's really important to note that research is super important, and that without research, we can't continue to develop any types of cures or treatments for dementia. And make sure you support everybody that's doing presentations on this. So thanks everyone for your time. I really appreciate it.
Thanks, Tara. That was really insightful and empathetic experiences, and we really appreciate you sharing that with us. Next, we have another one of our researchers, Dr. Lucy Vivash. Lucy is a research fellow and group leader in the Department of Neuroscience at Monash University. Her group is currently working on a new brain imaging technique to provide earlier and more accurate diagnosis of brain disorders known as tauopathies. She is also running a nationwide clinical trial involving the new medication sodium selenate, which she's trialling as a novel treatment for these tauopathies. Today, Lucy will discuss some of her neuroimaging research in the context of current and emerging treatments for dementia. All yours, Lucy.
Thanks, Terry. So thank you, everyone. So I'm just going to give us a quick whistle-stop tour through imaging of dementias as well as the current and emerging treatments. So we'll follow on quite nicely from the introduction that David gave us at the beginning. So first off, I just wanted to give you a little bit of the understanding of the lingo that I'm going to be using. So what is it when I talk about neuroimaging, and what do all of the different acronyms that I'm going to be talking about mean? So first off is MRI, which most of you will have heard of. So you can see a nice MRI on the image here. So this is a brain imaging technique that we use to determine structure within the brain. So when we're thinking about neurodegenerative diseases and dementias, what we're looking for is brain atrophy, so shrinkage and neurodegeneration or loss of neurons within the brain, as well as looking for potential other causes of the dementia, such as a brain tumour or a brain bleed or some other kind of major injury that might be the underlying cause of the dementia. And then the really cool thing, which is my favourite, is PET. So PET is a functional imaging technique. So when we talk about PET, what we're talking about is a way of measuring particular processes that are occurring in the brain. So the most commonly used tracer for PET is fluorodeoxyglucose, or FDG. And this measures the amount of sugar uptake within the brain, so is able to tell us what areas of the brain are acting normally and what areas are under functioning or not functioning at all. So when we're using this for dementia, what we're really looking for is areas where there's less activity than we might be expecting. And so this is a beautiful PET image on the right here. Very, very pretty to look at. The really cool thing with PET, though, is that we can look at pretty much any kind of pathological or process within the brain. So with respect to dementias, we can look specifically for amyloid within the brains in patients with Alzheimer's disease or a mild cognitive impairment in pre-Alzheimer's. So this image here shows a nice PET scan, amyloid PET scan. And the sort of reddish areas here are the areas of increased amyloid within the brain that we typically see in someone who has mild cognitive impairment or Alzheimer's disease. With the buildup of toxic proteins within certain neurodegenerative diseases, we can also look at tau using PET. So this is one of my beautiful tau PETs, and the orange areas that you can see in the center of the brain are the areas where there's tau accumulation within the brain. So this is pathogenic in this case. This is the cause of this person's disease, and this is a person who doesn't have a dementia per se, but has a movement disorder that is caused by an accumulation of tau. And so one of the things we're working on is to better understand the contributions of all of these different brain imaging techniques in differentiating and diagnosing different dementias. So just for today, I'm just going to run through a couple of the more common dementias and the imaging signatures that we'll see. So first off, Alzheimer's disease. So on the MRI, if we are looking at someone with Alzheimer's disease, what we're looking for is reduced volume or atrophy, brain loss in areas of the brain known as the entorhinal cortex, the hippocampus, and the temporal lobes. And so these are all areas that are involved in memory. And so this makes sense with the presentation of Alzheimer's disease. We're seeing this very specific loss of brain within these temporal regions here. So the images on the right showing the progression of the neurodegeneration that we see. And it's quite particular that it's occurring in the temporal lobes, more so than the elsewhere in the brain. So also with Alzheimer's disease, if we look at the amyloid PET, so here, for example, the middle image is a patient with Alzheimer's disease, the left image is someone, a normal healthy control, and the right-hand image is someone who has frontotemporal dementia. So we see that the patient with Alzheimer's disease has this excess of amyloid, and as David said in his talk, the accumulation and buildup of amyloid in the brain can occur 20 to 25 years prior to the onset of symptoms. So this is the typical pattern that we would see with someone with an MCI or an Alzheimer's disease. And with PET in Alzheimer's disease, we also see quite specifically a reduction in the temporal and parietal regions. So this is the region at the back of the brain, these green areas here, where we're seeing less activity compared to that we see in the frontal cortex. So up the front of the brain, it's nice yellow, orange, red, whereas up the back of the brain, we're only seeing this very kind of dull green area. So that's indicating that there's less activity in the brain there. And that's a very well understood sign of Alzheimer's disease in these patients. So just to go on to a couple of other common dementias. we also talk about tau PET, my favorite, where we do see an excess of tau within the cortical regions. I don't have an image for this one, unfortunately. But just to go on to some other dementias. So frontotemporal dementia is a particular interest of ours. And on the MRI, as David said, we tend to see atrophy of the frontal lobes. So here it's all at the front of the brain, which corresponds to the symptoms that we see of personality change, difficulty with complex tasks. And in these patients, we also see sort of more severe atrophy within the temporal lobes, which can also lead to some of the cognitive problems with these real sort of knife edge images that we see with a relative preservation of the posterior cortical region. So up the back of the brain, it still looks quite nice and normal and healthy, but these frontal areas are showing significant brain loss. So if we looked at FDG PET, we also see this reduction in this activity in the frontal region. So up the top here, we've got a patient with frontotemporal dementia, and down the bottom is a healthy control. So you can clearly see a difference in the two patients with less activity in the frontal regions in the patient with FTD. Amyloid PET isn't useful in these patients because they don't have any amyloid, so an amyloid scan will come back negatively, and tau PET scans can show increases of cortical tau, so tau within the brain in these patients as well. So just to move on to another very common dementia, vascular dementia. So in vascular dementia, the MRI tends to show white matter lesions. So these very bright areas of white signal around the ventricles here. So this is caused by vascular risk factors. So as David said, no smoking, please. Try and control high blood pressure, keep a nice healthy diet, and this will reduce your chances of developing vascular lesions that we are seeing here. So as you see, these are quite extensive throughout the brain and can occur in any particular region. So they're not wholly specific in their location. This then leads into what we see in the FDG PET scan. So for example, in vascular dementia, there tends to be diffuse abnormalities in the patient that tend to reflect the diffuse lesions that we see. So in this patient, it's quite asymmetric, you can see. And this FDG PET is also used to rule out a mixed dementia. So whether or not someone might have Alzheimer's as well as vascular dementia. And again, an amyloid PET is also looked at to see whether or not there might be amyloid in the brain as well. So lastly, I'm just going to touch on dementia with Lewy bodies. So this is the Parkinson's dementia that David mentioned. So in this case, we don't really see any specific atrophy patterns on the MRI, but the important thing is that in this disease, we don't tend to see any atrophy of the hippocampus and the temporal lobe. So these memory areas that are typically affected in all of the other dementias that I've mentioned. On the FDG PET, we tend to see this reduction in signal in the back half of the brain again, but with a relative sparing of this cingulate sign. So you can see at the back here, this orange area, just quite discrete on its own. That is a specific sign of a dementia with Lewy bodies. Again, amyloid PET is used to look at whether or not there's any amyloid as well. It's quite common, but by no means diagnostic. And then the last thing is to just mention that dopamine transporter PET can be used here. So in patients with dementia with Lewy bodies, they don't have any of the dopamine transporter in their brain, so they have a reduction in that signal. So just very, very quickly, I'm just going to touch on the diseases, the current treatments for dementias, and it's very quick because unfortunately there's very little out there. So donepezil, rivastigmine and memantine are the standard treatments which are symptomatic but by no means affecting the underlying cause of the disease, and these have been shown to provide symptomatic relief and have benefits in both Alzheimer's disease and mild cognitive impairment, as well as some potential benefits in dementia with Lewy bodies. These do not impact the underlying disease process, but do provide the symptomatic relief. And unfortunately, they don't have any benefit in frontotemporal dementia, although there is some evidence for a small benefit in dementia with Lewy bodies and vascular dementias. So antidepressants, anxiolytics, and antipsychotics can also be used to alleviate symptoms of disease, but again, don't have any long-lasting effects. So I just want to touch on aducanumab because everyone's heard about that. So that is the anti-amyloid therapy that Biogen have released in the last year. So this is great at reducing the amount of amyloid in your brain. So the left-hand images are before treatment with aducanumab, and then the right-hand images are afterwards. And you can see that it definitely gets rid of the amyloid in your brain. Unfortunately, it doesn't seem to have any impact on cognition in these patients. So it's not actually alleviating their cognitive decline, which is a shame. Unfortunately, it also has some side effects which aren't to be sniffed at. And with the where we're up to at the moment, it's been approved in the US, rejected in Europe, and hasn't been decided whether or not Australia is going to approve it, but we're not holding our breath here. So the other thing to think about is that there are current ongoing trials with aducanumab and a number of other medications for this disease. So if you're interested in participating or know someone who might be interested, this is our email address for that. And very, very lastly, I just want to talk about my baby, sodium selenate. We are currently developing this as a treatment for both FTD and PSP. And we've found that it does suggest some slowing of cognitive decline in patients with greater selenium levels. So this has also had effects on behavioural decline and reducing the brain volume loss in patients with BVFTD who were treated with sodium selenate. So we're now going on to a phase 2 trial, so recruiting patients across Australia and New Zealand, looking at behavioural variant frontotemporal dementia with sodium selenate. And if you're interested in hearing more information about that, then you can contact this email address on the page here. I'm very sorry to have gone so late over time. Thank you very much.
Thanks, Lucy. It was a great overview, and we can feel your passion for this research area coming through. So our next speaker is also an early career researcher, Dr. Juliana Silva. Sylvia is a research fellow in the Department of Neuroscience at Monash University. She's currently working with animal models of Alzheimer's disease to study how the disease comes about, and it's also its relationship with epilepsy, which is a not uncommon comorbidity in patients who have Alzheimer's disease. She's going to give us some insights into the current understanding of the fundamental biology that underlies dementia. Over to you, Juliana.
Thank you, Terry. So just following on from what has already been said, we have heard from Lucy and David about what is dementia and what is the clinical presentation of dementia. And we also learned that a dementia brain has a lot of atrophy, as you've seen from these amazing images that Lucy has shown. But in order to understand what causes the atrophy, we need to look closer in the brain and perform a more microscopic evaluation at the tissue level, so to understand a little bit more of the mechanisms of disease. So this is what we call neuropathology, which is the study of diseases of the nervous system, looking at the tissue. So as you can imagine, having access to human brain tissue is not an easy thing. So this can happen through small surgical biopsies or also from autopsies. So our brains are composed by many different cell types, but mainly by neurons and also glia, a group of cells that we call glia. So the glia are the cells that actually support neurons, and neurons are, our main cells of communication, the way through which our brain sends commands to our body, and that it communicates between regions. So what happens when we look closer at an Alzheimer's brain is that, as it has already been mentioned, you can see these purple dots here. It represents the nucleus of the cells, the nervous cells. And in this first image here in the amyloid plaques, you can see this buildup of this brown aggregation of proteins around the neurons. Is called the amyloid plaques. And on the next, photo, you can see the buildup of another type of protein, which is called tau, and it folds abnormally in Alzheimer's and in all the dementia types, and it aggregates inside neurons. So these are two of the main features of Alzheimer's disease. This is not part of a healthy, normal aging. This is a pathologic feature. And also for tau, we know that, like Lucy touched on it, it's not specific for Alzheimer's disease, and we do have a group of dementia types of diseases that are called tauopathies, and all of them have the characteristic of having this abnormal buildup of tau inside the neurons. So these proteins, they can actually over time start spreading out across the brain, and they can form these stereotypical patterns and start accumulating in certain brain regions. And as disease progress, it starts evolving and getting into different regions of the brain. So this abnormal accumulation of amyloid and tau is actually the main cause of this atrophy. So it's damaging the neurons and ultimately leading to the death of these cells. And as I was, scrolling through Twitter this morning, I just saw this really nice animation that I thought would be really nice to represent what, these tau tangles or abnormal buildup of tau inside the neurons can actually do to it. So for those who are not familiar with this, I'll just play. It's a very quick video. So you can see the neurons firing, communicating with each other. And once these tau tangles start to accumulate inside, you have the loss of these connections and shrinkage of the neuron, and ultimately leading to the death of the neuron. So as this happens, you can imagine in the tissue, you will have all these cells dying, and you will have the atrophy happening in the brain and the shrinkage of the brain. So another thing that I wanted to touch base on, which is mainly what I've been interested in working with, is that it can be a new feature, a new thing for those who are listening here today, but something that we've been seeing more and more recently in the literature is that there seems to be an overlap between these Alzheimer's pathology, the amyloid and the tau that I've just talked about, and also epilepsy. So we know that these epileptiform activity, or these electrical abnormalities in the brain can be, can occur in Alzheimer's disease, and is one of the major clinical features that is actually shared between the Alzheimer's and a specific type of epilepsy that we call temporal lobe epilepsy. But however, the relationship between epilepsy and Alzheimer's or dementia is actually not very well understood. We know that temporal lobe epilepsy patients also have cognitive decline, and as I said, Alzheimer's patients, we're seeing that they can have seizures that we're missing. So most of the seizures that happen can actually be non-convulsive, and so they can be easily unrecognized. And there have been studies that show that about 10 to 20% of patients with Alzheimer's can actually have these unnoticed, unrecognized seizures. But considering that these can be, misdiagnosed or underdiagnosed, this number could actually be a lot higher. But what's interesting in this aspect here is that there are a few studies showing that when you compare patients with Alzheimer's that have epileptiform activity and patients with Alzheimer's that don't, there seems to be a greater decline in cognition in those who have epileptiform activity or these silent seizures. So this is really an opportunity for intervention, another opportunity for intervention in the Alzheimer's pathology that could actually help improve these cognitive deficits. So what we're doing here in the epilepsy and behavior group, in which I am part of at Monash, is really trying to understand better this relationship between epilepsy and Alzheimer's, and some, what can we do actually to improve these. So I'm just going to quickly go through a couple of researches, really interesting research that is happening here in our lab, in our department. And the first one is Anna. She's a PhD student, and she has just published a really nice paper, which I will be really honest with you. I won't go into detail because it's not my main area of expertise, but she did some network analysis and found some genes that share specific, that she found specific genes that are common between epilepsy and Alzheimer's, temporal lobe epilepsy and Alzheimer's. And these defects in these genes can actually lead to, the deficits in the neuronal communication and cell metabolism and regulate excitability, so generating epileptiform activity, for example. And we have a really interesting study as well with Jen, who is also a PhD student in our group. And she is studying how a combination of visual and auditory sensory stimulation can create brain rhythms, can make the brain fire in a specific rhythm in a particular frequency, specifically at 40 Hertz, and how this can actually be beneficial to the Alzheimer's pathology. So there seems to be a really interesting way of helping to clear this, buildup of amyloid in the brain using this sensory stimulation. And she has seen in the context of the Alzheimer's and epilepsy is that this sensory stimulation can actually decrease seizure severity. And what is also very interesting is that she's, I think, if I'm not wrong, ready to move into the clinic space. So she's going to be testing these sensory stimulations in our epilepsy clinic here. And this photo is not from the setup that we'll have here, but it's actually from one of the clinical trials that is happening in the US, looking at this interesting methodology. And this is probably how it looks like to have. So what happens, sorry, I didn't go through. What happens is that you have lights flashing and a sound that is at a particular frequency. And when you're exposed to these light and sound for a certain period of time, which, if I'm not wrong, might be an hour or so, that can make your brain go into this specific frequency that can be good for helping to clear the amyloid from the brain. And then lastly, I and Dr. Olaf from the Department of Immunology here at Monash, we've just started collaborating. And what I've been really interested in looking at is how we can use dietary interventions in preclinical models of Alzheimer's disease initially and epilepsy to see how we can actually modify the Alzheimer's pathology and maybe understand a little bit better of this epilepsy susceptibility. And if we can control the epilepsy in Alzheimer's, that would ultimately then lead to an improvement in the cognition and Alzheimer's pathology. But this may seem a bit odd, I don't know, for some, but we all know how diets can have a huge impact in our health. And so the rationale behind this of using modified diets and dietary interventions is actually that we know that some of the microbials in our gut can influence our brain and vice versa. We know how the microbiota in our gut can be really altered in some diseases, including Alzheimer's disease and epilepsy and other neurodegenerative diseases. But more importantly, this is also a window of opportunity and another perspective, another way of trying to influence disease outcomes. So when we have, dysbiosis of this bacteria, that can actually lead to increased, tau and amyloid deposition in the brain. So if we can make our bacteria, our gut more healthy with, probiotic administration on maybe, diet, that can actually have a good impact in the brain and helping clear these proteins and these abnormal buildup. And that's it. Thank you.
Thanks, Juliana, for that really exciting talk about your research and your colleagues. You can see again your passion coming through in the way you spoke. It's fabulous. For our final scientific presentation, before we start to the Q&As, we have Associate Professor Nadine Andrew. Professor Andrew is a senior researcher and research data lead for the National Centre for Healthy Aging. She is a recognised leader in generating and translating knowledge in the application of big data to health services research with a focus on chronic diseases of ageing. Of particular relevance here tonight, she's co-leading a Boosting Dementia grant using linked data to provide robust prevalence estimates for dementia. Today, Dr. Andrew will talk about supporting consumers to engage with the large data platform to inform research and gain knowledge about healthcare. Over to you, Nadine.
Thanks, Terry. So I'm just going to present a slightly different view to the other presenters. So a bit more of a big picture view around how we can use data to inform dementia research. So I'm just going to start by explaining a little bit about what big data is. I'm then going to talk about the study that Terry mentioned, that we're applying it to dementia in, and then I'm going to talk more broadly about how we're engaging consumers in our big data research. So big data in health really involves large population data sets, and it's usually analysed using a computer or software. So we're often looking at tens or hundreds of thousands of people and looking for patterns in that data that might provide insights. And it's really important for things such as understanding population risk factors for diseases, measuring how common conditions are within society, so conditions such as dementia, identifying gaps in healthcare delivery. And because the data is often collected over long periods of time, we can use it to look at whether or not changes in policy or changes in the way that care are delivered actually impact on people's health outcomes. Some of the limitations, though, are that often these data are held by different agencies or different organisations, and so you need to bring them together in a way that enables you to answer your research questions, and this can make it quite difficult to work with this type of data. So just in terms of our application of big data to dementia, we received an NHMRC grant. So Professor Srikanth and I have been running this project and really looking at how we can use big data to monitor dementia frequency, risk factors and management. So as many of you might know, dementia is very common in Australia. We've got about 40, nearly 500,000 people living with dementia. And this is predicted to triple by 2020 unless we can find effective interventions to prevent this. But it can be actually difficult to get an accurate understanding of how many people are living with dementia. At the moment, government usually rely on hospital data to make those estimates and to guide where services are delivered. But we know that dementia is often poorly recorded as a condition in the coded hospital data, which is what they're relying on. And so what they're working on is often an underestimate of the true numbers. The other way they can determine it is looking at smaller long-term studies, but these often are not accurate when you try to apply them to the whole of our population. So what we were trying to do in our project was to develop a set of algorithms to better be able to estimate dementia in big populations and then give those algorithms to government so that they can apply it to their data. And then we want to be able to also use these algorithms to help guide perhaps where we can target some of the healthcare services that are provided to people living with dementia and their carers. So in order to develop our algorithms, we needed to have two groups of people. So we needed to have people who were living with dementia, and so this group we were able to gain access to through our dementia and memory clinic down at Peninsula Health. We then needed to go into the community and recruit another set of people. So these were people who we then did some tests on to ensure that they were not living with dementia. And so the reason we needed these two groups is that when developing an algorithm, and so an algorithm is when you have different sets of data, so lots and lots of things that might predict something like dementia, and you put them together in a mathematical model, and you want to be able to test how well it differentiates between people who do and people who don't have dementia. So obviously it was important with this project for us to be able to engage with the community in a positive way. So the first strategy we had was we had a consumer who was actually part of our study team. So he helped us write the grant that we submitted to the research funder. And then he provided feedback on relevant aspects of our study design and our ethics applications. Once we had the funding and were designing the project, we also presented it to the Peninsula Health Older Person Community Advisory Group. And we sought feedback from this group on the best way for us to go into the community and to talk about our project in a way that would enable people to engage with our recruitment strategy. The next part of the study then was to get as much data as we could so that we could improve how well we could develop these algorithms. So the main source of data that we were working with was electronic health data that's contained in the electronic medical record system within Peninsula Health. And that had data from acute care, rehabilitation, community care and outpatients, as well as pharmacy. And then we've linked that data to the blue data, which is held by the state government, and then with the data in the green folders that are held by the Commonwealth government. we're still in the process now of working through the data, but once we've done that, we'll apply the algorithms to all people residing in the Frankston-Mornington Peninsula region. So that will be around 221,000 people, and we'll use that to get our estimates of how many people in that region are living with dementia. And then from that, we will be able to provide some accurate data to government and use some epidemiological type modelling to apply that to all of Australia. We're also going to revalidate our algorithms within a population over in the US associated with the Mayo Clinic. So what we're hoping to get from this project is a system for being able to monitor dementia and risk factors over time. Also the ability to create geospatial maps. So I've got an example there that one of my colleagues did, to be able to identify, hotspots or areas where there may be lots of people living with dementia, so that our services can be targeted to those areas, and use this to inform some of our future work within the National Centre for Healthy Ageing. I'm just going to talk a little more broadly now about some of the work that we're doing down here. So this is a partnership between Monash University and Peninsula Health. And it has come about because within the region we have a very well-defined population. A very large proportion of the people living in this area access their healthcare through Peninsula Health. We have a very diverse population, both in terms of socioeconomic diversity, and we've got some parts that are clearly metropolitan, but some of the areas down the bottom are classified as regional. We've also got a lot of people aged over 65 living in the region. We have some of the highest rates of dementia in Melbourne, and we have approximately 60 aged care homes also within the region. So when we were setting up the National Centre for Healthy Ageing, we thought, obviously one of the really important things for us was to be able to effectively engage with the community. And especially with the data work that we're doing, which is, for example, the work that we're doing in the dementia study, we wanted to be able to make sure that consumers were well informed about what we were doing, but also had the opportunity to drive some of our research agendas and to provide input into the types of questions that we should be using the data to answer. And so rather than trying to figure out how we did this, we actually thought, let's co-design this with the consumers. So far, we've run a couple of workshops, and I've got Emily and Kim there who have been running our co-design workshops, and we're getting the consumers within the region to actually design our strategy for engagement. Another important component is some work being led by Dr. David Snowden and Lucy, and they are also developing a consumer engagement strategy so that we can start collecting outcomes routinely from everyone who comes through the health service that relate to things that are important to people. So things such as quality of life, for example. And so I've just got some pictures here of our consumer groups hard at work, helping us develop some of our strategies. There we go. And then finally, this is another piece of work that we're engaging with. This will be a really important way for us to expand our consumer engagement. So we've been having discussions with a group in the UK about bringing on board a digital consumer platform. And so this platform will allow consumers from all over the country and internationally to engage around certain projects, but also to engage around certain topics that may be of interest. It has a really strong focus again on co-design and co-development, with the opportunity for consumers to become involved in whatever phase of the research process they wish to be involved in, as well as being able to provide educational platforms for consumers. So we're really excited about this partnership that's still in progress, but this will form a major component of the work that we're doing within the National Centre for Healthy Ageing. Okay, and yeah, that's all. Thank you very much.
Thanks, Nadine. Someone's obviously decided that I need to be censored, or at least my image does, because I can't restart my video. It's probably very, very wise and reasonable from whoever has censored me, but now I can start my video. Okay, so you only got a small reprieve from me. There we go. All right, back again. So thanks very much, Nadine. That was wonderful. We've gone a little over time with our researchers. As always, researchers, they're so passionate about their area that they can't help but keep talking about it. So thank you, everybody, for your wonderful contributions. We might extend a little bit longer, so we'll have at least 15 minutes or about 15 minutes for questions before we have to close the event. So I've got a series of questions that have come through on the Q&A, and we'll just read them out and then direct them to various researchers to answer. So firstly, with dementia symptoms, first question is, what can people do to help prevent Alzheimer's disease? So I don't know, Nadine, do you want to take first stab at that?
Oh, I'm not sure I'm well qualified for that. Can I handball that one to Shrikant?
Shrikant's come in.
I just saw him pop on.
Yes, good man. I was looking for you, Shrikant. So Shrikant is a geriatrician with a clinical expertise in dementia and will be the perfect person to answer that question.
Thanks, Terry. Can everyone see me?
Yes, and we can hear you.
Excellent. Look, that's a really important but tough question to answer. But as Professor Darby mentioned during his speech, there are certain things that we can do and usually must do fairly early in our lives to try and prevent the risk of dementia. Now, if we were to prevent or delay dementia, that means we do good things for ourselves such that even if we were to develop dementia, it happens later in our lives than earlier. And some of the simple things to do early in our lives is to have a good lifestyle, which is easy to say, but tough for some people. Physical activity as much as possible. And we're not talking about athletic sports all the time. We're talking about something simple as regular walking would be beneficial. Keeping connected with people and engaging with people on a level that keeps you stimulated, motivated, and happy. The quality of life of connection, that seems to be really important in trying to prevent cognitive decline further in life. And then there is a whole range of things that come with that, apart from diet as well, which is part of lifestyle. And that is to make sure that we have essential parts of, sorry, my phone is. It seems that my Siri is listening to me and answering me at the same time. To prevent things that could cause harm. So, for example, checking our blood pressures at regular levels once we reach a certain stage of adult life, and making sure that our metabolic health, such as the presence of diabetes or other things like that, are well controlled, and check being to the GP frequently enough to prevent these vascular risk factors, as we would call them, because the more we have those risk factors, we could have things like strokes and other things happen in the future, which could unmask dementia. So those are probably the most important things we can do earlier in life. But as we get older and are closer to the time of potentially getting dementia, still keeping active and ensuring that our diets are good would be a good thing to do. Sorry, Terry, pass it back on to you.
No, that's great. Perfect answer, Professor Shrikant. So next question is for Dr. Vivash. The question is, I'm wondering how or why sodium selenate benefits higher in people with, it benefits people with higher selenium levels.
So I should probably just clarify that, because I had to sort of zip through that at breakneck speed right at the end there. So essentially, what we found in that study was when we measured the selenium levels, which is a byproduct of the sodium selenate treatment, as a proxy for how well the patients had complied with their medication, we found that the patients who had the higher selenium levels didn't show the cognitive decline, whereas the patients who didn't really show a change in their selenium level, so maybe weren't quite so compliant with the medication, continued to show cognitive decline. So that was a poor explanation from me, because I ran through it at speed.
Thanks, Lucy. So a question for Tara McDonald. What advice do you have for someone who's facing caring for a person with dementia?
Yeah, thanks. My piece of advice to begin with was that it's important to have people around you to care for, to be an additional care partner. They often say with children, you know, it takes a village to raise a child. It takes a village to care for a person living with dementia. And that's because also the differences in behaviour and the changes in the brain change that happens, if you take on all of that responsibility on your own, you'll get worn out, and then you're no good to anybody, including yourself. So my number one thing would be, make sure that you build an army of people around you, for not only the person living with dementia, but also for yourself. And also make sure you remember that you are important, and it's important that you have a life as well. And I think that's one of the things that I was really, really focused on when my dad was diagnosed with Alzheimer's disease, was to make sure that my mum knew that she had support and that she wasn't doing this alone. And there was no need for her to do it alone, even though she thought that it was her responsibility.
Great. Thanks, Tara. So next question is to Dr. Juliana Silva. Juliana, at what stage of Alzheimer's disease are these epileptic seizures occurring? And if they are mainly unrecognised early, mid, or towards the end of life?
Yeah, so some of these studies that I've shown, they actually have looked into some more severe types of Alzheimer's, so the early onset ones, and these abnormal, epileptiform activity can happen pretty early on in the disease. So this is why it's something that it's interesting to look at, and it could be a potential avenue for disease modifying therapies if we do find these epileptic seizures and start treating them early on. That can actually help reduce the cognitive decline over time. So I would say in the more severe types of Alzheimer's, and also early on in the stage of the disease.
Okay, thanks, Juliana. So back to Lucy Vivash, Dr. Vivash. The trial that looked at aducanumab that significantly reduced amyloid in the brain, were the patients post-symptomatic, and were the brain cells already dead? And can you comment on why it may not have shown, despite reducing amyloid, that there was an improvement in cognitive decline?
Yeah, so that's a great question. So I think you kind of hit the nail on the head there, the questioner, in that essentially the problem is that these patients had mild cognitive impairment or mild Alzheimer's disease, so they're already quite a long way into their pathology. David and I mentioned earlier that you can have amyloid in your brain for 20, 30 years prior to the onset of symptoms. So that's already when the mechanisms that underlie the pathology are working, or working for the ill in leading to the neurodegeneration and the neuronal loss. And it's only when that neuronal loss hits a critical point that you get the cognitive symptoms, because the brain's very plastic, the brain's very good at compensating for abnormalities and for things going wrong. So I think the problem with that is that essentially when aducanumab came along and was shown to get rid of all the amyloid, it did that no problem. But all it did was take all the amyloid out of the brain, but the brain is still atrophied. The brain has still undergone neurodegeneration. And so all that was happening was you were getting rid of one pathology, but it didn't suddenly reverse all of the 10, 20, 30 years worth of neurodegeneration that had slowly been building up. And so that's why we didn't see any of the cognitive benefit that everyone was hoping for. So I think that's probably the story of it. Now they are looking at dealing with people who are earlier on in the disease, so people who have amyloid in their brains but don't yet have symptoms, and also looking at using patients who might have genetic types of Alzheimer's who are yet to be symptomatic, to see whether they can treat people prior to the onset of symptoms to see if that can stop them developing Alzheimer's and dementia. But that is, you know, a work in progress and will be the kind of thing that comes out over the next few years.
Okay, so next a clinical question for Srikanth. I'm wondering how much of the benefit of diet and exercise is actually attenuation of vascular risk factors, and if there's been any models that have been used to examine this relationship.
That's a good question. The question is, have any models proven it? Very few, if any, but the logic is really sound. And the reason why it's difficult to study this in the long term is these risk factors have to be treated effectively earlier in life, and you have to follow people for really long periods of time over many years to see if it has actually prevented things like stroke and other things that you're talking about. But I think the logic is really simple, that if you do prevent high blood pressure, if you treat high blood pressure, diabetes, etc., you're not going to get things like strokes. And strokes have a clear association with an increased risk of dementia. So the logic is that if you attend to your vascular risk factors, then you are lessening your risk for the future. The modeling itself is difficult because of the length of time that it's required to follow people for events that are happening.
Right, and a quick follow-on question for that was, there's mention when smoking came up a number of times in relation to vascular risk factors. What about vaping? Any data on that?
With respect to dementia itself, probably not.
Yeah.
But it's not a good idea to either vape or smoke, in my opinion. So the less we do anything of that sort, the better it is for us generally.
Great. Thanks, Rico. So our final question, I think I'll direct this to Tara, is as family members or friends, how can we encourage someone to seek help if we suspect they might have dementia?
Yeah, well, I think it's important to note before we go into that 50% of people who have dementia actually never realize that they do. And as the other person that was on the video said, that, you know, his wife knows that she has Alzheimer's disease, but, you know, doesn't really recognize it. And so sometimes that can be really tough, because as the person that's standing on the outside, you're looking at it going, something not quite right here. And so that's where it comes back to building that army around you, to being able to support the person until they actually can work out, you know what, maybe I need to go and speak to my doctor. But keeping in mind, they actually may never get to that point, because if they actually don't know that they have dementia, they may not ever actually want to go and seek that help. So the best thing that somebody can do is actually educate themselves about dementia and educate how they can best support that person until they actually realize that perhaps they need to go and see somebody or see what's going on within their brain change.
Great. Thanks, Tara. So that just brings us to 7 o'clock, and so we need to unfortunately call the evening to a close. There are still lots of other questions, and hopefully our researchers will be able to get back to you, some of you with answers, or have another opportunity to ask your absolutely excellent questions. But on behalf of the Central Clinical School, I'd really like to thank the CARE Committee and the organisers, in particular Loretta and Bridget, who have done a fabulous job in putting this together tonight. We'd like to thank the Alfred Foundation and Monash University for their support of this program and webinar series. And would like to thank all of our absolutely fabulous speakers for giving their insights into the clinical and translational aspects of dementia research, and also the lived experience of dementia. Special thanks to Malcolm and Tara for sharing their lived experience, their personal lived experience journeys with us. And most of all, thank you all out there in Zoom land for joining us, and I hope you found this informative and interesting, and we hope to see you again in future seminars. So have a great evening, and all the best to everybody. Bye.